Hi, everybody. This is Leanne, and I just wanted to provide you guys with a quick video recording of the Connect Care training to navigate triage. So hopefully we will be able to get through all of this in just less than 2 hours is my goal. So what we're going to cover today is going through actually reviewing how and demonstrating how to arrive a patient and go into the 5 identifiers that are going to be required at triage when you bring in a patient. We're going to talk about how to complete a triage assessment, talking about some of the terminology in there about triage disposition and destination, as well as how to room a patient, looking at isolation status, and then of course pre-arriving our EMS patients and what do we do with our critical processes. We are also going to review our waiting room management and how our triage lead is going to go about flagging patients and managing flow. And then we're going to do a quick little CTAS review before we have a chance to get to the play environment, and I'll show you this stuff in real time. So just so you know, for the plan for go live, which is on Sunday, this is being recorded on Friday, just before we go live here, but we will promise to have super users 24/7 at the triage window and EMS triage for the month of November. There's lots of quick reference guides in binders at all of the triage locations, as well as available on SharePoint. This video itself will also be available on SharePoint, but I will have hopefully also emailed it all out to you guys as well. And you can also use your dashboard. So within critical care environment, there is a dashboard with all the critical care, or sorry, not critical care, Connect Care training information. And then all the very site-specific workflows will be found under SharePoint. So the good thing about Connect Care is there's lots of really great little buttons. It's just about managing, figuring out when to use them and where they all belong. So one thing we're going to start with is actually arriving a patient. So when you arrive a patient, it's no different than we have in SEC right now. When the patient comes in, you go down to add a new patient, you're just arriving them now. The nice thing with Connect Care, though, is once you arrive a patient and you put information in, that chart is not a dummy chart like it is in SEC where we have to wait for registration to confirm and all that kind of stuff, and you can't do orders. In Connect Care, once you finish arriving a patient, that patient is open and available for people to start documenting on, whether you to do triage or at the bedside for a cardiac arrest. So one of our roles at triage is to make sure that the patient is put in properly. So there's 3 different pathways to follow. After you hit the arrive, and arrive is always this lovely little ambulance button, so you can't miss it. You either are going to find the patient that is currently already in Connect Care and see if they exist, or we have the option to arrive a temporary patient or an anonymous patient. You are going to see this little thing up here as well that actually is and it says expect temp patient. I want you to ignore that, and we'll talk about why temp patients can cause us a bit of trouble. So ignore this particular thing. Our primarily button is going to be this arrival button. So what do we mean about verifying a patient? Well, because we're not just putting in their first name, last name, and sending them to registration, we have to do something called patient verification of registration. So the 5 identifiers that we are required at triage to ask for is going to be your last name is 1, first name is 2, so you got 2 covered. Date of birth is a 3rd identifier, and gender is going to be a 4th identifier. After that, you are just going to be able to add either an Alberta Healthcare number, phone number, or confirm their address. So right now we have a habit of either getting their AHS card, a driver's license, something with their name on it so you can actually input that information. They need some type of confirmation what their date of birth is. I can't just walk up to triage and say, my name is Leanne Narina, this is my birth date, if I have no personal information data, so I can't prove that. The proof can be anything. It can be a driver's license, a current student ID card, a passport, a treaty card, a landed immigrant status card, something that proves that you are who you say you are. And then your job as the triage nurse is, once you get the basic information, is to go in and actually just verify that they match. So what verification is, so when we go in to arrive a patient, this is your SEC screen. This is your trackboard, your lovely little arrive button over here. That's going to open up this patient lookup screen. So I'm going to go ahead and put in first name, last name. The beauty of Connect Care is you can also put in last name, first name. Some patients have maybe 1, 2, and 3 names, and you're never quite sure which is their first and last name. So you can go ahead and put that in, put in their gender over here, and again, you can go ahead and put in their birth date as documented. You're going to go ahead and find the patient. When you find a patient, if they already exist in Connect Care, this screen is going to pop up. And the beauty is that Alberta Health Services, for I think probably since we decided to go live with Connect Care, some person is inputting every current patient with Alberta healthcare status. Um, Alberta healthcare status into the Connect Care system. So that means that when if you pull up a patient who's currently registered as an with Alberta Health Services, this screen should pop up. So now you're going to say, okay, I had Mrs. Abby Punch in here, and now you're going to confirm I've got their first name, last name, I had their date of birth and their gender. So I just need one more verifier. So I can go ahead and say, can you give me your phone number, or can you confirm to me your address? What you don't want to do is say, is your phone number 780 blah, 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 because then they'll say, yeah, and you have no idea that if that truly is. So you do need to get them to give you their phone number or give you their address. If that is true, obviously there might be more than one person with that similar last name. This is their Alberta healthcare number. You can either refer to that, or you could have actually punched this in right at the top where the name was instead and get right to the right chart. So once you do those 5 identifiers, you could go ahead and select, and this patient is now live in the environment. Patients still, who are going to the waiting room, are still going to get seen by registration. Even those going back to the bed, registration will come out and see them anyways. They do a few things. They will update emergency contact information. People may need to update their addresses, and eventually we're going to start seeing patients' profile pictures in here. They obviously have to get consent for it, but we might start seeing patients' pictures up here, which is kind of neat because it's another way of verifying them when they come into the department. Now, what happens if you can't complete those 5 identifiers? This is going to happen, obviously, if people, number one, are from out of province or out of country. They are not going to be in the Connect Care system because they don't have Alberta healthcare numbers. So you're going to still go ahead and put in their first and last name. You can go ahead and try and put in their date of birth if they have some type of card with them. If they don't, or maybe they don't have ID that confirms their date of birth, then what you can do is put their stated age. And how you do that is over here with Y minus their age. So year minus 7 would do a guesstimation date of birth, or Y minus 52, whatever it is. Also, please don't forget to put in gender, and then you can make them temporary. Now, the key and the caveat to a temporary patient is they must be stable. If you create a temporary patient because you can't identify them and they're going right back and they're in extremis, they're in some type of distress, and we need to get treatment going and a physician see them, that chart is locked until registration confirms their identity. So similar to SEC now, where you can't put a CAT scan in and all that stuff. So we don't want to do this for patients unless that patient is rock solid stable, able to walk to the waiting room, able to wait to get up to the registration desk to actually have their identity confirmed. Okay. So this would be anybody that does not have photo ID, or doesn't have a confirmed birthday, or is actually from out of province and would not have an Alberta healthcare number. Now, what happens if the patient meets those criteria from out of province, but is actually really quite unwell? So they either need to get back to the trauma bays, they can't identify themselves because they're unstable, they're unresponsive, they're one of our cardiac arrests or our level 1 traumas. Then we're going to quickly just identify that patient, similar to now where we use our unknown charts. In Connect Care, these are called anonymous charts rather than unknown. So you would open up that patient lookup screen would open up when you go to arrive a patient, and you're just going to click this anonymous button and your unknown chart gets randomly selected for you. So no more having to type this in, which is excellent. So you're going to click anonymous. The chart's automatically going to come up for you. We really need you to select gender. Again, this is significant, especially for getting blood products. We know if the patient is coming in as male or female, so that's super important. But also to help identify. So we may have more than one unknown patient in our department, and it's really nice to be able to identify between gender. The other thing we're able to do is also put in a guesstimation age. So on our patch forms with our level 1 traumas, you're going to we have a 30-year-old male coming in as a, car pet injury or whatever. You can go ahead and put year minus 52. That'll later be confirmed after the fact, but at least it helps to navigate all of our unknown patient charts. Now, one thing with unknown charts that's different from SEC is currently registration. When we have an unknown patient, registration will go back and identify them and change their name in SEC. This registration in Connect Care will still go see these unknown patients. However, that unknown name will constantly be up on in Connect Care until the patient is discharged from the hospital. So this means when that patient leaves Emerge and goes to ICU or the cath lab or up to the trauma unit, that unknown chart will still be, that unknown name will still be attached to that patient. And the only way the nurse on the inpatient unit is going to know who that patient is by hovering over. So you can imagine the nightmare up in trauma or up in ICU with how many unknown patients they may have. So this is why we're really asking, and we'll go through who we should be identifying as anonymous and who we should really try our hardest to try and identify with those 5 identifiers. So this is a summary table, and this is printed and going to be up at Triage for you guys. So can you positively identify them? Yes, make a new patient and find them within the Connect Care system and get them registered. If you cannot positively identify that patient with some form of ID, if they're unstable, you're going to make them anonymous. If the patient can wait, do they have enough identification to confirm their identity? And if they do, we can go ahead and make them temporary, and registration will put them through the process. Now with Connect Care, as soon as you hit that select button, whether it was for a patient already in Connect Care, a temporary patient, or a anonymous patient, an armband is going to print. So this armband is going to come out, and this is your lifeline to your patient because it's going to come out with their barcode. So once you get that printed out, I really want you guys to grab it and put it on your patient immediately. This quickly identifies, we don't want random armbands lying around and trying to remember who they go to. So make sure you go ahead and print out this armband. And the other nice thing about it is if you want to give medications at Triage, you remember you scan your patient, scan the med. This is important, as well as your blood glucose. So now with blood glucose, you're going to take your lovely glucometer here. You're going to scan and register yourself with your ID to open up that glucometer. Then when it comes to patient ID, instead of you guys faking a patient ID number, which we all do, you're going to go ahead and use that glucometer to scan the patient. It's going to identify that patient right away, do your blood glucose reading. And then when you actually get around and you really want to get in a habit, once you dock that glucometer, that blood glucose will feed right into the patient's Connect Care chart. So you don't need to actually document it. It will feed right into it. So great idea to make sure you put the band on right away, and it makes it super easy either to do a blood glucose reading or scan that patient if you're going to go and do a protocol for Tylenol or Advil or something at Triage. Now, just be on watch. This little screen called Encounter Selection may pop up if you select a patient, especially if they're found in Connect Care and they've identified themselves. Consider the patient that's sitting at the Lougheed Emergency Department in the waiting room for an extended period of time, gets frustrated, decides to leave. They don't let the triage nurse know, and they just drive themselves over to the foothills. They arrive to us, you put in their 5 identifiers, and they're like, hey, just let you know, this patient already exists in a Connect Care chart because we have one big Connect Care family, right? So that Connect Care chart is going to say, hey, they already have an encounter at the Lougheed. Is this the same chart? And we're going to say, no, it's not. So the quick and easy workaround is just to call the Lougheed and tell them, we have Mr. Joe Smith here. Could you discharge him from your waiting room or dismiss him from your waiting room? If you're having challenges with that, registration can help to facilitate this. Hopefully this patient is stable enough to work through this process. If they are not and they come in unstable, then we would go ahead and just register them as anonymous, and eventually things would all come together. Lots of people have asked about ED treatment plans and how they're going to be brought up within Connect Care. As soon as you select that patient and do your 5 identifiers, if you're able to find them in Connect Care, an ED treatment plan will pop up. So what it'll do is show up in your patient storyboard over here, and a flag will show up to tell you that there's something in there. Again, we're going to have little workthroughs and posters up at Triage and throughout the department to how to do this. But basically, you have to go into their storyboard and go to clinical systems plans, and there's something called Calgary Historical Data, which is where you're going to find their treatment plans. These are not only our emerged treatment plans, but the Tom Baker has let us know that some of their cancer and chemotherapy patients, they really want to expedite them getting dexamethasone. Those patients will also be flagged in here as well. So keep an eye out for this flag and go ahead and open it up and review what's information is in there, because it's a lot of the Connect Care family sharing information on that patient. Protocols can still be done at Triage, and when we get to the play environment, I'll quickly show you how to do those protocols. But these are our referral protocols. So patients with pregnancy-related complaints over 12 weeks, the process is the same. They still have to be presenting to Triage. They have a pregnancy-related complaint. You are going to call the L&D Triage nurse and say, hey, I have patient X with this concern, and they will accept that patient. You are going to continue your triage just like you normally would and get that patient through. Same thing with postpartum complaints and your PCN referrals. The difference with PCN referrals is that we are still going to continue. Well, actually, it's not different. We're staying completely the same, and it's all paperwork. You do not need to print off an ear anymore, though, for those patients going to L&D, because L&D will be able to see that patient's encounter in Connect Care. Because these patients, so the pregnancy-related, the L&D referrals, and your PCN referrals, these patients, when you get into Connect Care, once you get them and have a plan to get them up to L&D or off to PCN, just like we currently do, we'll need to remove them from our triage waiting room, but we are not discharging them. Patients that are in the waiting room cannot be discharged. They have to be dismissed. Terminology difference with Connect Care. So you're going to go into a referral. So we need to refer them in our triage disposition, which I'm going to show you in the play environment. And you're actually going to go and actually send a disposition, to L&D referral or PCN RN referral, which is to your PCN. And then you need to dismiss them from the waiting room. So when you actually go up in your trackboard and hover over your patient, you're going to see this dismiss button. Instead of a discharge button, you'll dismiss that patient and put as for ED dismiss, diverted elsewhere, and you can say for L&D protocol and then dismiss that patient. That will take them off the trackboard. This is different for some of our other processes where we move patients to off the floor. That's only if the patient is going up to an inpatient unit that has been admitted. L&D patients are not an admission. So from a triage standpoint anyways, you are referring them. So we are taking them out of our system. And when they get upstairs to L&D, they're going to start a whole new encounter. So what about our EMS arrivals, patch forms, and critical processes? So the good thing is our patch forms, they are staying the same. With patch forms, they are paper patch forms, and we are not changing those. So they are going to continue as they currently are. There is technically a place to put pre-arrival information, which I will show you in a moment. But the concern with us is, one, Connect Care is a huge learning curve right now. Do we want to go all electronic just for patches? The other concern is if we have 3 patches going in at the same time, how are we going to have 3 computers available for people to put in that information? So right now we're going to stick with patch forms, the paper process. Nothing has changed. We are going to complete the call-out processes. All of those are still the same. People still have pagers. So despite the fact we know we have that secure chat information, we are not using secure chat for our critical processes because the physician needs to be actually looking at a computer screen. So pages are still the same. You're still going to be in there and actually calling their CTAS1 doc and your clinician, the same normal processes that we're doing. The unit clerk is going to be up there, and the beauty of this is the unit clerk is going to be up there 24/7 now. So the unit clerk is, instead of priority if they are short-staffed or on break relief, that they preferentially covered BPOD, they're now going to the priority place to cover is going to be triage. So if they're short-staffed, triage is a priority to cover. And for break relief, there'll always be a unit clerk up at triage. So this is really going to help us with the page-out process. So what's going to happen with our triage lead, what's new and improved with this, is once you take that patch form, the triage lead or somebody, maybe it's going to be the EMS triage nurse, depending on how busy we are, you are able to enter pre-arrival information and put a hold on a bed for critical patients into Connect Care. I say this if there's time. If the patient is literally going to be here in 3 minutes, the priority is to get the pages out, call the clinician, ensure you have a treatment space available, ensure the team is aware that things are going on. All of those things to me to be in place, and then get that pre-arrival. If the EMS triage nurse is trying to do this, it also is important to make sure that obviously incoming EMS patients also need to be triaged, and putting pre-arrival information should not delay the triage of another patient. So again, we'll see how this flows in real life and how cumbersome it is. I think once you get used to putting it in, it's going to be really slick. The first few times it's going to feel a little cumbersome. So we'll play with that in real life. The unit clerks are going to help us do a big part with our processes, with our patches. They are going to, number one, we are no longer going to be handing that unknown chart to registration. So they need to be aware that somebody's coming in. So the unit clerk is going to inform registration of incoming critical patients. The unit clerk is also going to make a photocopy of that patch form and keep one copy. They're going to do some documentation as to time for patch or pages getting called back and all sorts of stuff. They are also going to ensure that that patch form gets scanned and sent and forced into the Connect Care chart. It will then become a permanent part of the record. So if for some reason we were not able to enter that pre-arrival information, that information has not been lost. We know the one that goes to the patient bedside, especially now where we don't have paper. We don't have paper. It's going to be its one lone piece of paper maybe, and it could quite easily get lost. They're also going to do really good thing is once you actually pre-arrive a patient, which means that patient is actually going to be in our expects on our ED manager. The unit clerk can go in and actually force print an armband and labels. This is important because at the triage EMS triage desk, that patch form now will have an armband and 9 patient labels on it, sitting there waiting for the patient to arrive. Now, first question is going to be, who do we make anonymous and who do we pre-arrive? Well, just like I mentioned, that if we have too many anonymous or unknown patients, it's going to be a bit of a nightmare for the inpatient unit. So we're going to try our best to identify as many as we can. So those that we feel that we should make habit of making anonymous would be obviously our level 1 traumas. Make them, if they meet the level 1 criteria and we're doing a trauma team activation, then go ahead and make them anonymous and pre-arrive them. This not only helps expedite them to the bays, but when we put pre-arrival information in and have that patient in expects, when the team is doing their pre-brief back in Trauma Bay 1, they can actually go in, look at the patient that they are expecting in the pre-arrival, open up that patient chart and actually read the documentation that we put in the pre-arrival information. Instead of calling triage saying, what are we getting? What's the vital signs? Blah, blah, blah. They can actually go in and actually look at that information. So that makes it super helpful for pre-briefs. Stat strokes, so the stroke process, which we'll review in a second, but those that stroke has asked to do a stat stroke page out, we are going to make anonymous and attempt to pre-arrive as well. Cardiac arrests, again, if you have time and they're not showing up on our door, one, we're making them anonymous, and then you can pre-arrive them if you get a heads up. Unresponsive patients, and as well as those imminent delivery and newborns, are going to be anonymous patients and do as much pre-arrival information as we have the opportunity to do. So those patients that we are going to do our best to identify and register are going to be those strokes that stroke has asked us to direct to refer to the CTAS-1 physician. They are still going to be CTAS-1 patients, but they are going to be try and register them. And any STEMIs, again, patients, multiple unknown patients going up to the cath lab could be a bit of a safety risk. So we're going to try and identify those patients. So what does pre-arrival look like? Well, when you hit that arrive button after you select that patient, whether they're anonymous, temporary, whatever, well, this patient particularly would be anonymous. There's 2 buttons up here called arrived and roomed. As soon as you click those, it actually starts the triage timer to say that the patient's feet are actually physically in the merge. We don't want to start that timer until the patient actually arrives. So to create an expected patient, there's an expected date and time. So you're going to go ahead and put a T in here for expected date is T for today, and expected time is going to be now plus 30 minutes. So N plus 30 would be the patient's ETA is 30 minutes or 60 minutes or 5 minutes, whatever it turns out to be. If you have the opportunity to put a hold on a room, that's awesome. If sometimes that's not a reality. Um, but you could put a comment in here would be plan for trauma bay 1 when patient leaves, whatever. But if you can go ahead and put a hold on that patient's room. You are not going to fill out the arrival date or time because that says boots on the ground that they've actually arrived. You can change the means of arrival. The options here are ground, air, and no ambulance. So you can go ahead and put that in. And then what we really want you to do for the pre-arrival, and this is the information that the staff back in the trauma bays waiting for your patient will be able to see. So the complaint will be carped CPR in progress or whatever it is. So it just helps them to kind of, oh, I need to get Lucas and I should get this, or penetrating chest wound, right? So it's just nice. So when they look at that patient, this complaint is automatically there. However, it also helps you as a triage nurse to determine which of the unknown patients or pending arrivals, when they show up, you'll see a whole bunch of unknown patients. You can look at the complaint and so, hey, is this a carped? Okay. The pre-arrival information, so once you put them in expects and put them in pending arrivals, there is the pre-arrival information that you can go ahead and do. So there's one, what team did we activate? Well, we activated the trauma team, the stroke team, or we activated our ECG physician. If what we have up here is listed, then there's a little comment box over here that looks like a piece of paper. You can open up that and put like a baby blue recess or something. Really important to note that this does not trigger the page. So this is just actually documenting that we've done something. So this is, instead of writing on the chart, trauma team activation called out, you're just basically charting that you've actually called out trauma. The page is still, like I said, will be done by the unit clerk and they document the times on their end. All sorts of things in here. If you have, you kind of services page with the cath lab, however you did that. Underneath here is all sorts of stuff about vital signs, information, and there's additional information way at the bottom. I just didn't want to make it so small you couldn't see, but there's additional information at the bottom that also can give a brief story, just the same kind of story that you got on that patch form. Okay. That patch form with the armband and labels are now going to be taken out to the EMS triage desk. And then when the patient arrives, the EMS triage nurse is going to do a few things. So number one, they're going to give the patch form and stickers to the crew and take it to the designated area. If this patient is arriving by stars and you know that they're landing, then you can go and take that information back, hand it to the nurse back in Trauma Bay 4, wherever they're coming to. The triage nurse can now technically, if they know the patient has arrived, they can go ahead. They don't have to stay in the trauma bays. They could go back to EMS triage and actually do all of the triaging right from the EMS triage window, or they can continue to do it back in the bays. Again, this is something I think we'll have to figure out on the fly. What works best for you. But basically, you can go ahead and give that patch form. EMS can be going down the hallway to Trauma Bay 1. You're going to overhead your team. That patient is en route to Trauma Bay 1. You're going to go into expects and you're going to find that correct patient and you're going to pull that patient up, and you're either going to, if you had a pre-assigned room, you're going to click roomed or arrived and assign them a patient care space. That will now time the patient as arrived right now. Once that you are kind of complete in there, you're going to complete the arrival, and then you're going to go in and complete your triaging. So the pre-arrival, all that stuff is not triaging. Triage is still required. The expedited triage, at minimum, you need to put in a chief complaint, a travel and exposure screening, CTAS scoring, and you can also put in a brief note, which actually just covers patient sent to Trauma Bay 1, CPR in progress. And again, we'll show this in a demo in just a second. So with the critical process, what's changed and what has stayed the same? So these are all of our critical processes. And for the most part, you can, actually, I would say 100%, the processes, the criteria, and the call out is exactly the same as we're going to do it. It's just the slight little variations we need to make for Connect Care. So for the stat stroke processes here, it is exactly the same. We still want patients who present with stroke-like symptoms less than 24 hours. You're going to ask for the unit clerk to page the stroke team. The stroke team is going to call back and they are going to direct us to either page out as a stat stroke or have the emerge doc to see. The differences in Connect Care is just how we arrive that patient. So with a stat stroke, if they ask us to page out a stat stroke, we are going to make this patient anonymous and do pre-arrival information if we have time. The importance is this, is we did a few sims and it just kind of expedited getting that patient a CT in less than 10 minutes. There's T and K that needs to be done, and it just worked better to get into that stroke narrator. So we're going to do it that way for our stat strokes. If this patient is a stat stroke coming in through rapid, which maybe the patient got seen at the Rocky View and the rapid is coming through as a rapid patient for stat stroke, that patient is actually already going to show up in expects. Rapid has been alive with Connect Care since day one. So rapid immediately, any rapid patient will be showing up in our pending arrivals or expects. They're the same thing. And so and they may have already been identified. So you'll need to know that if it's a stat stroke coming through rapid, that patient will already be in your expects, and you can just go open up and arrive that patient on arrival and not have to make them anonymous. They still, of course, are going to be CTAS ones at the moment. The strokes that are stroke is asking to have emerge doc see first. We're going to do our best to arrive that patient just to try to help minimize some of the unknowns in our department. With the caveat, if this patient comes in extremis, needs to get back because we need to tube them, is seizing, or is just completely not able to actually confirm their identity because of the extensity of their stroke, then go ahead and make them anonymous. Now, what about STEMIs? STEMIs, again, we're going to try not to pre-arrive them. We can't pre-arrive patients and put pre-arrival information without identifying them. So you can't go ahead and put that information in. So we are not going to pre-arrive them. When they arrive, we are going to register them with 5 identifiers. The same thing applies to rapid patients if these STEMIs are coming in from another site. So that's going to be the rapid process. These are the STEMIs that are going to come through LifeNet. LifeNet still is available. You are still going to print off that ECG. You are still going to have the unit clerk page the ECG doc. You are going to take that ECG and scan it on the printer and email it to the FMC IC STEMI at ahs.ca. That is all still the same. When the emerge doc comes in, you are going to go ahead and, when the patient arrives, depending if it determines it's for a cath lab patient, we're going to go ahead and triage that patient as per normal. If we've decided, or the physician decided, the interventionalist, we're going to send them to cath lab. The team activation you are going to go in, which we'll look at, is an option for triage, and you're going to do team activation with STEMI cath lab. And the triage disposition is what we're going to switch into, is we are going to say send to cath lab. Again, we'll demonstrate how to get that up there. So it's going to be a send to cath lab. We know that a lot of these STEMI patients sit in E1, 2, 3, or just right in front of the triage nurse and quickly get all their meds. To do that in a quick fashion, how to document them off, just go into your STEMI narrator, and you'll get familiar with this at your bedside a lot, but you can go ahead and within your triage, you can pop right into your STEMI narrator, go ahead into that STEMI narrator, and it's got your little quick access drugs. Triage that patient and try to get that over with as quick as possible. Go into your STEMI narrator, and there's a whole bunch of those meds that are quick access. I will warn you though, and you guys will notice very quickly, there's lots of meds that we frequently and will always give to a STEMI, and even to our strokes that don't show up in the STEMI narrator. These would be like your clopidogrel and your ticagrelor, and I think heparin, and I want to say TPA, yes, TNK, sorry. And the reason is because some of them are weight-based, and some of the other ones have different dosages based on age of patient. So they couldn't put them as quick checks. That does not mean you can't order them. You just have to order them long ways through the orders tab. And ideally, hopefully will be our physicians putting in all med orders like that. And then they can put the med orders in, and you're just administering those meds and signing them off under your MAR under your patients. So that's a whole other workflow that'll just be we have to live in the moment for sure. Now, when the patient's going to the cath lab, things you need to make sure, number one, they have to have a completed triage. You're going to have that armband printed out. Please make sure you place it on the patient so they can identify it. And just like now in SEC, we need to put an admission in before they go to the cath lab. So how to do that in at a Connect Care is you're going to go under the Orders tab, and all you have to do is put bed request in under the search button, and this ED to IP bed request will come up. Your service is cardiology. You're going to put the interventionalist name is as provider, and then you can do a quick request patient cath lab from Triage or ED, whatever you like, and accepts. And that's a quick little bed request. This patient is now admitted into our department. So even though they're physically leaving from Triage, they are now actually an emerge patient, which means that we are going to discharge them, not dismiss them like we did that L&D referral. So you're going to discharge them just like you would if they were a patient back in a treatment space back in B12. So part of the processes is you are going to complete a discharge. You're going to do a care handoff. So there's this ED update button. You're going to go to care handoff and just say ED update to cath lab. And then you're going to go to the big disposition tab and say admit to hospital, complete that information, and then drag and drop that patient to OTF, which is off the floor. So when they don't get physically removed from the emergency department, what they do is get moved to OTF, and then that's the way that cath lab can yank them from the OTF to put them into their Connect Care environment. Okay. Now, what about our lovely mums delivering? Well, there's a few things that, number one, it stresses us out. Nothing has changed. We still make that baby blue recess process. Our unit clerk will call out the baby blue page out, and then as somebody also needs to call the L&D charge nurse to let the L&D team know. We're obviously going to get our team organized. If we get a heads up, that's perfect. And getting our team organized and planned and prepared. If they delivered our front doors, we still are making that call out process and doing our best. So a couple different things within Connect Care, and I actually think it makes it easier than the current registration process. If the baby is delivered within the walls of Emerge, so we are going to arrive mom, she is going to be anonymous. Always time, we're not stopping mom to ask for 5 identifiers. We are going to make her an anonymous chart. If you have a chance, we're going to put in pre-arrival information if we have a heads up. She is going to be a CTAS 1 and off to the trauma bays. When the baby gets delivered currently in our department, our process is somebody has to go triage that baby. And it's always been confusing about how do I name them? What do I do? Is it baby female? What do I do? You don't do that anymore at all. In Connect Care, mom is the anonymous patient. Mom is the patient, period. But here she's going to be anonymous. When baby gets delivered, the baby ends up being a little attached entity to mom's anonymous chart. So within mom's chart, you can create baby delivered, gender, time, all that kind of stuff underneath mom's chart. And then later what happens up in L&D is they will separate and register baby as they would do and create 2 charts. That is not our problem. L&D is taking 100% ownership of this, and rightfully so. We don't want to mess it up. So all you need to be responsible for is making mom a chart. And when that baby gets delivered, what you as a bedside nurse might be asked to do is call L&D, please document delivery time, that's super important, and gender of child that comes out. And then L&D or you are going to be making a phone call up to the unit clerk in labor and delivery to say baby was delivered. There's a number of steps within here. And again, we have a workflow for delivery about what we need to do in Connect Care. But from a triage standpoint, that's all you need to do. If a baby is delivered prior to arrival, so what has been happening, either it's a home birth, like a midwifery delivery, and baby's coming in extremis without mom, or like the other day when we had mom deliver behind Tim Hortons, baby is expedited transferred to our department and mom comes in a separate unit. Regardless, if mom and baby is on mom's lap and has already been delivered before they arrive to our department, both patients need to be triaged. Both patients are going to be anonymous, and you are just going to triage baby, arrive baby, just like you would any anonymous patient. Anonymous, an UNC chart will come up. You're going to put the gender in of that baby. And for date of birth or birthday, you're going to put T for today. and that is their birth date. And then you're going to go ahead and register that baby. Okay. And then mom would get a separate chart. So back to Rapids, I did mention this before. So we are, for the next little while, going to still get the faxes from Rapid. You're going to start getting used to it, Triage, seeing the pending arrivals and expects get filled up with our Rapid patients. And you can regularly, when you have a moment, look in those, hover over those patients. You can click on them and do a chart review and actually review the information of the patients coming in, which is really lovely. They are going to continue to give us paper Rapid faxing the Rapid forms in for the next while until we get used to looking in pending arrivals for those incoming Rapid patients. Rapid patients will still have an emerge physician, or should, I should say, should still have an emerge physician attached to them, and that information will be available. The same process, if that emerge physician is on, you're going to let them know when that patient arrives, that their patient from Rapid has arrived. If there's not an emerge physician attached to that patient, then you're going to let the Rapid patient know, or sorry, the Rapid physician who's on call at that time when the patient arrives, that a patient has arrived. They are going to show up under expects or pending arrivals. They're similar things, and you can open up under chart review to see what's going on. If when the patient arrives, you're going to go down to expects and you want to click on that patient to arrive them, just like you would a pre-arrived anonymous patient, but you might see this little icon next to the patient's name. This icon with a little stretcher tells you that patient is currently still registered at the sending department. So again, the same process, you need to call the LAHEED and tell them that they need to discharge that patient or move them to OTF. When they move them to off the floor at their site, then we can pull them into our department. So we're going to room that patient in Triage as per normal process. You're going to drag and drop them in ED Manager to get them into a treatment space. And the most responsible physician who had ownership of that patient will be paged or secure messaged. So what do we need to know about patients going to the hallway? So not everybody's going to go straight back to a bed or be Rapid. All of those medics that are coming to the hallway are going to be paged as per normal. You're going to arrive them and identify them. And when that armband spits out, you are going to label that patient as well with that band. One other thing that we need to do is go ahead, if you guys remember how to print lab labels, you're going to go to print forms, print off one label and hand it to your EMS colleagues. What they need to do is they will need that patient information in order to submit their PCR into Connect Care. So they will tell, I think it's a CSIN number or something they need off that patient label to feed their PCR into Connect Care. If medics do not know how to do this, we will have a little cheat sheet for them. It is not our job to do it for them, just so you know, but we will have a reference tool for them. The next thing you need to do is make sure the patient is allocated to the EMS waiting room. So you don't want them appearing to be in the main waiting room. And how to do that is in ED Manager, I'll show you can drag and drop. But the other way is if you just hover over or have a patient highlighted and right click, this option button will show up when you right click them. There's the waiting room option here at the bottom, and you'll see that we have 3 waiting rooms. We have waiting, which is main, EMS waiting room, and then we also have the main intake waiting room, which is technically our main triage area, but these are patients allocated to go to intake. You will notice we do not have a D main waiting room or a fast track main waiting room. We were only allowed to create 3 waiting rooms. So these are the 3 we created. If a patient needs to go to D pod or what's going to be called fast track in our system, we're going to have a way to, I'll show you a way to allocate the triage destination, and it'll just have to be marked there. All right, what about flow and flagging patients? So number 1, and what I'm super excited, there's no more paperwork. So it seems weird. We're not going to have papers to shuffle and charts. So it's going to be a little bit of a learning curve to get over that. But what we have is a whole bunch of beautiful screens. So you as the triage lead will actually, if you're taking over lead for that day, you're actually going to have a dual screen. So you're going to have one screen that we recommend you have ED Manager showing up on, and the other one is the track board. And on the track board, there's a ton of columns that you have access to, but the main ones you want to have access to are the waiting room, this MRHP, which is your most responsible healthcare provider, which is basically what our emerge physicians look at to see what patient they should go see next. And then you want to look at your pending arrivals, which is where your rapid patients and those EMS expects are going to show up. So under ED Manager, if you look at it, it's very colorful and it looks really overwhelming. But this is our entire department up here, and you're going to get used to the colors and what they mean. Obviously, brown is, dirty beds, but it's going to be like just like now where we see that pink bed that flags that a patient has a bed. You're going to get used to those colors to say, oh my God, they have a bed, and you're going to, get in there to know you're going to have a discharge. Below the line here, as soon as I get over here, so this below the line here is all your waiting rooms. So here's your main waiting room. You've got your EMS waiting room, I think your intake waiting room, and your pending arrivals. You can also make screens bigger and smaller, so you can actually make your waiting room area bigger. This is completely customizable and really quite lovely. So you have lots of time to play with that. Also, the great thing about this ED Manager is you can click on a patient that's sitting in your waiting room and actually physically drag them to a treatment location. So it's just kind of preventing you from clicking back and forth to multiple things. So it's a really quite slick little tool. So the roles and responsibilities for triage lead and triage nurses in regards to patient care and the majority of the flow options are not much different than what we currently have. The triage lead is still they're currently responsible for maintaining priority numbers and getting patients into the department. What we're asking now is because we have no priority numbers anymore, the triage nurses are not going to be doing that anymore. So there's no priority to put in, but the triage lead has two new responsibilities, but they take it away. So one, the triage lead, once the patients have been triaged, the triage lead is responsible for watching the waiting room, and they're going to put priority flags on patients. So the waiting room patients are going to have priority flags on, and this basically means who gets a bed next. Okay, and we're going to review that in a second. They're also going to put on sequencing flags. So sequencing flags look the same, but they get put under the MRHP. So under the MRHP column, this is actually what our physicians will see on how they should sequence who they go to see next. So that's the triage lead's responsibility. They're also going to monitor the flow and arranging patients for moving to treatments areas. They're going to work with the charge nurse clinicians and our resource flow liaisons to help to manage the flow of the department just like they currently do. And for the most part, receive patches and put that pre-arrival information in or delegate that off. The triage nurses, if you're in that role for the day, then your job is obviously to complete triage notes. You are going to attach armbands to patients. You need to allocate patients to the proper waiting room. You need to help the lead make the best choices. So you saw the patient, tell them this is the waiting room they're in. So all those EMS patients, they can see, I've got 8 patients sitting out there. Allocate patients to the proper waiting room. You also need to put in a triage destination. So right now we've gotten a good habit of putting into different B main waiting room and D main waiting room and putting in the plan column about needs monitored bed and all that stuff. You don't need to put that in the plan column now because there's a great little triage destination. You're going to go in there and say the patient is going to go to intake, fast track, acute, monitored, recess, or AMH. And I'm going to show you what these mean in a second because it's like a little bit different. But if you allocate the patient's triage destination and you've created a proper CTAS score, it's really going to help your lead figure out your priority of patients as well as allocate what patients are priority for physicians to see. Okay. So how we do the waiting room management. So this is what your waiting room. So this is in your track board. Your waiting room screen is flagged here, and the patients are ordered in the waiting room screen, technically who should go in next. So it's based on acuity, length of stay, all that kind of stuff. And this is a patient sitting in your waiting room. So when you look at it, if you look at acuity specifically, there's a CTAS 1 waiting to come in. So you would think in theory that should be your next patient to come in. But then because your triage nurses are so helpful, there is something called a destination column. So this is what they put in as a destination and where that patient should go. So here we've got a CTAS 1 that's supposed to go to intake. I personally, that's surprising to me. I did not do that. But you're like, well, you know what? I have a A3 is open. And if you really feel that this CTAS 1 should go to intake, I'm probably not going to take my A3. I would probably also be questioning my triage nurse why they made this a CTAS 1 to go to intake. So that's a whole other story. However, if the next patient that's at the top of the list is to go to intake, I would look like, well, I actually have an APOD bed. And according to destination, this is my next intake bed or my next monitored bed. This is my BPOD bed. This we don't for recess is kind of confusing, and you can see how it's not very helpful if you as the triage nurse did not put in a triage destination, because now I have to guess what you meant. Okay, so putting in the destination really helps when I actually look at who according to CTAS should be next to come in. Now, that's not the only thing you're doing. So as the triage lead, you're also going to be putting in what's called priority placement. So this is a whole other column. And the priority placements that we have available at triage are next, which is, this shows up as kind of like a fire hydrant, which is, I want this patient in next. This is my sickest patient. They've either been here a really long time. It flags to me, just like you guys currently do, where you move those paper charts to the front. So you've got all those patients waiting to get in the department, but you've already kind of physically pulled the next 3 or 5 charts that you want, and you've moved them to the front of the folder. The same kind of thing is going to happen with these priority flags. So alarming would be the next one in, and maybe it's the next one to BPOD or the next one to the monitored bed. The green dot here that when you put on this, it is next to room. So this is the next person I want in a room, that you're going to put people before others. When you put a blue dot in, then it's called next. This is a next in CTAS. So if you have, this is one's perfect for that situation where you have a whole bunch of CTAS 2s and you've got the, belly pain who's got the 8 out of 10. You've got your person who's got the migraine. You've got an abdominal pain who's, eating chips, but they're saying their pain is 12 out of 10. And then you've got your little old granny who's kind of in an arrhythmia, who's looking kind of pale and yucky, or that chest pain that you've started a chest pain protocol and they're sitting as a CTAS 2, but the other 3 have been here longer. You can go ahead and actually put this next in CTAS on that little chest pain person or your 3rd degree block or whatever it is, and it's going to say, I want this person in above all the other 2s. So it would, just regardless of time frame, it would prioritize that patient and bump up the CTAS line. The other tools you have are this watcher, so you want to keep an eye on. So somebody made a great comment about that belly pain that's, been vomiting, and you're like, they're stable right now, but I'm just kind of worried about them. You can put a watcher on them. So maybe they're not the next to go to a care space. You've got 5 others that kind of meet these criteria, but you're going to keep an eye on this one. And maybe after those top 3 or 5 get into treatment spaces, this little watcher one is maybe the next one you want to put in to say, go to care space for the next room. The transferred in ones, so just like now with patients coming in from Rapid or transferred in from other sites, we've been asking you guys to put them in the top 10. Then what's going to happen with this little transfer in is it's basically doing the same thing. You're going to put this little icon in and you're going to talk about zipping them in. So this just tells you, you're going to say, it doesn't change order of priority, but what it just is flags to you is saying, I should really think of getting this patient in sooner rather than later. Or you can look at that patient is zipping them in for that return from ultrasound. Return from ultrasounds, those ones are not going to show up under expects like they do now. The patient is just going to have an encounter and say they were here last night for an ultrasound. You could go ahead and zip them in because they've been waiting and you're just going to get them through their intake area. The extended wait icon is, you do have a triage timer that goes red actually. So if they've been in the waiting in the waiting room for more than 8 hours, that triage timer is going to go red. Even prior to that, you can also put an extended wait. So if you have a CTAS 2 that's been a ridiculously long wait, or like that CTAS 5 that just keeps getting bumped and bumped and bumped, you can go ahead and put an extended wait. It does not change the order of being seen, but it put a flag on you. So you're like, who's that guy that's been here forever? Because you can't really put a flag or a paper clip or however your communication tool to yourself has been right now. This just puts a flag in your reminders that you should be watching that patient. Okay, so now let's go back and actually look at what that looks like in real time then. So now I've got my acuity scoring. Here I'm in my waiting room screen. My according to acuity and time, this is what my order of to see is. So I've got my CTAS 2 here, my triage times. I've got a 21-hour wait here, just ignore it. Holy cropies. And now if I put in actually a priority sequencing, here what it found out was that you've actually flagged that patient as next to go in. So that's a CTAS 2. It was a bizarre behavior patient. We have a notification column, which is very much similar to a plan column. You can write stuff in there. Just be aware that anything you write in the notification column feeds into the patient's story. So it will become a permanent part of the patient's chart. So it should be pertinent and professional information, I guess I should say. But I actually think it's actually really good to put in here waiting for A18 to be cleaned. So here I've said already, they're next to go in. They've already had an extended wait. I know they're a CTAS 2, but here I've actually documented why they are still waiting in my waiting room. So waiting for bed to be cleaned, waiting for whatever. So it's not a bad thing to have it permanently part of the chart. If somebody goes ahead and puts another notification comment in, it will fall off this screen, just so you know. So just, kind of use it wisely and making sure that at triage, we're using it to communicate appropriately, either to the lead or the lead, you're communicating that to yourself or to whoever's covering you for break. The other little symbols we have in here, there's a time frame on here. So this guy with back pain has been here more than 8 hours now. That's flagged here. I may not have put that on, but I don't know the whole story. In here, you guys have a next in CTAS. So this is saying out of all of these fives, this is the guy I want to go in next. And that's perfectly reasonable. Down here, you've got a little watcher on. So this is a back pain. And you know what? This guy's been here a long time, but I'm really watching this guy. So maybe you're thinking, I don't know, he just is super uncomfortable. You're going to need to get him in for pain control. Whatever the reason is, you put a lovely little watcher on him. And then down here, you've got a guy for general weakness as next to in. So when I actually click that, this patient is going to actually move to the top. But maybe this general weakness, even though it was a CTAS 4, you want this in this next A bed. So you've got next waiting for A18, the next A bed that opens up. You've got your next 2 flagged, and this is going to be your next patient to go in. Again, hopefully over here, there is also your triage destination, assuming this patient can likely go to intake in our area. Now, this makes sense because this is actually worthwhile. I've got 1, 2, 5 patients that I'm like, out of all of these, those are the ones I'm really worried about. I really want to kind of go back to this screen. So if we go back to this screen, we had the acuity, we had the destination, but look at all those priority sequences. And I would argue that this actually makes it useless. If you have so many, this is next in CTAS, next in CTAS, I've got 2 3s next in CTAS. How does that make my job any easier? I've got another 2 here next in CTAS, and these guys are next to room. So if you use too many priority sequence flags, they almost become completely useless. So this is a couple reasons why, as a triage nurse, I do not want you guys putting in priority flags, even if you're back in EMS. It's similar. I want you to the triage lead to kind of manage that priority list. These are priority for patients to get from the waiting room, whether from EMS waiting room or to the main waiting room, to the next treatment space. If we use too many of them, they become arbitrary. So really, I would kind of all triage leads need to figure out how they want to work this, flag them. To me, it's just like you do now, where you already have those next few in line and you've kind of pulled their charts because you know these are my next ones to go to intake. These are my next ones to go to an A pod bed or B pod. So figure out your way to flag those and make use of them in your best way. All right, so that's number 1 job is the triage lead is responsible for making sure patients get from the waiting room into the department. But the other thing, unlike now where the physicians just look at the department and see who's next in priority to be seen, they don't do that anymore. So they have their own screen, and this is what the other screen that we need to watch for is MRHP next to C. So in MRHP next to C, patients are going to now be listed in a different format, and physicians have been trained that if they're up for seeing a patient, they are going to pick the next patient on the list. Okay. So they're going to go ahead and pick that patient. So this patient way down here might actually be the one we're worried about. And so you as a triage lead were like, yeah, I just put that guy 3-day history of a headache. I just put him into B2 or whatever that's supposed to be. I need to flag him. So we can flag these patients. They are not priority flags, they are called sequencing flags. So the ones that we put on as priority flags in the waiting room, once you put that patient in a treatment space, they fall off and patients end up according to acuity and time in here. So what you then need to do as a lead is keep track of this MRHP screen and making sure that some of these other people are not falling by the wayside on a regular basis. So some of the priority flags or sequencing flags, my apologies, that you can go ahead and put in is the same thing. You're going to put in an alarming situation. So this may be you have put it in because you just walk this guy back with this belly pain and he's like, oh, that's right, it's a 12-year-old, so maybe not. I was going to say he's a AAA, but ignore the age. But for whatever reason, you think this 12-year-old needs to be seen next, even though they just came in. Or maybe I've called you from the bedside and I've just reassessed this patient, or they're really uncomfortable and I've actually asked if you could bump the patient up or get the patient up in acuity, and then you can go ahead and put next to be seen for the physicians. You can have more than one next to be seen, and realistically, we have more than one physician. So this patient will be taken off by the physician next, and then the next physician who's available will take the subsequent one. So that's not impossible. As soon as a physician signs up for this patient at the top, it falls off the MRHP next to C screen. So these will all shuffle back up. We're missing those other two. We're missing the blue and the green dots. So next in CTAS and next to room are not available. So next in CTAS is not an option. So in here, what you might want to do is then, instead of, it's like, yeah, I've got all these twos to see, but you know what? Actually, I'd like to keep an eye on them. I would actually, it will not override anything, but this patient is uncertain presentations, vitals don't match story. So you're saying, I'm actually kind of worried about this guy. So if these two alarms were not up here and all you had was a watcher on this headache that you kind of was worried about was maybe a subdural or subarachnoid or something, the physician should maybe go see this one because you've actually said, I've got some concerns about them. But if there's a whole bunch of level ones ahead of them, they're likely going to take those level ones, but maybe just keep an eye on that one. The other one is obviously the extended wait. So the little clock still shows up there. It's concerning the patient's been way too long waiting. Maybe it's that CTAS 5 that keeps getting bumped, and our physicians are educated on what these sequences mean and how they're supposed to prioritize through that. Not to say that physicians will not continue to cherry pick at the end of their shifts. That's still going to happen. So, but we do have some things in place. This seems really daunting if you have to think of, let's say, a whole, 80 some patients in our department and you have to determine this. We are simplifying it a little bit in the foothills. So the bonus of the foothills for the lead anyways is MRHP next to C shows the entire department. It shows the entire department of patients in treatment spaces. So we are actually going to separate these out at the foothills into 3 separate areas. So we currently have an intake coordinator. Sorry, this should say intake. My apologies. So we are going to separate into 3 areas. So there's going to be area 1, area 2, area 3. So these are how it's going to look in your flow, your computer screen. Sorry, your Connect Care screen. Area 1 is actually covering your D-pod patients or your fast track. So if you have allocated a patient from your waiting room into fast track, those patients are going to show up for physicians under area 1. If you take patients into your intake area and they've gone from the intake main waiting room into intake, those patients are going to show up under the MRHP area 2 screen. This is nice because when your physicians are going to be assigned to cover intake for certain parts of their shift, it's not just covering the whole department. So they're not podding themselves 100%, but they are going to spend so much time to see fast track. They are going to be in intake for X number of hours, and I can't remember what they're going to be for certain hours of their shift. So while they're there, they are going to go under this area 2 MRHP, and they're only going to see patients that are in intake, and they're going to tickety-boo through them. In area 1 patients, they're going to flip through all those fast track patients. The beauty is area 3 is those patients in B-pod beds, A-pod beds, trauma, E-pod, and C-pod. You as the intake the triage lead are only responsible for allocating sequencing numbers for area 3 patients. This because the patients in fast track, Either the nurses back there, the patients are going to be listed in order of acuity, what our CTAS score was. If you have a patient in there that, as a nurse, you feel should be seen ahead of others, you can go ahead and put that patient in a bed and physically tell your physician, or you can go ahead and put your own sequencing flag on because it's not going to affect the rest of the department. Same thing if you are the intake coordinator in area, you are going to keep an eye on area 2. And in there, all those intake patients are going to be listed for the physician to see in order of CTAS. If you feel that there's other ones you need to see, you're going to allocate them in and you can go ahead and put sequencing flags on, or again, physically communicate to your doc who you want them to see next. So this takes some of that cognitive burden off the triage lead, that they now only need to manage these patients and not worry about the priority sequencing for or the sequencing for the fast track and intake patients. Okay, so it helps to kind of minimize the volume that you're going to be managing. So now you're already, and I think people already are aware of this, but on the MRHP next to C screen, they do not see waiting rooms. So a patient has to be in a treatment space. So this is a view of your ED manager. Patients have to be allocated a treatment space before they will show up under that MRHP view, whether that's area 1, 2, or 3. Anything below this line here, which is your waiting room, EMS waiting room, main intake, and expects, are not visible to your MRHP, so not visible to our merge docs. So the big challenge with this is that we know if the department is jam-packed, they often come see patients in the waiting room in E1, 2, 3, and they often, and we've got those patients sitting in EMS hallway, we don't want those to be ignored. We want them to be seen. So this is really important that we find a way to make sure that these waiting room patients get onto the MRHP next to C screen. So how we do that, so ensuring patients in the main waiting room. So let's say the physicians are like, hey, I need some patients to see, like I've got nobody, but I know the waiting room's got 50 million of them. If you move patients in the main waiting room into exam 1, exam 2, or E1, 2, 3, these are treatment spaces. And these treatment spaces will be visible under that area 3 MRHP next to C view. So you can go ahead and start filling them. So exam 1 and 2, well, except exam 1 especially, we put in our chest pain protocols. So you put that patient in that room, it's going to show up on your MRHP next to C screen. You can go ahead and maybe put that patient that's the mental health patient or your immunocompromised patient in exam 2 in order that you want to be seen, and that they will show up under MRHP next to C. You can still then put a sequencing flag on all of these patients if they're super sick and you want them seen ahead of patients that are actually in physical treatment spaces. E1, 2, 3 as well. You just go ahead and throw them into that, get the treatment, and put them back to the waiting room if that's what's going to happen. EMS patients, if we put them into treatment spaces, the problem is that as soon as we put them in a treatment space, they come off of the repack screen and it looks like we've actually transferred care or we've downloaded that patient. So we don't want to do this, but we want to flag all of those patients sitting in EMS hallway. We want to make sure our physicians are aware they're out there. So there is a quick little workaround. And again, there is posters going to be at Triage to easily work you through this. So we need to do something called force their status to see MRHP. So when you go into your system and you see so you as a EMS triage nurse, when you send a patient to the EMS hallway, before you're done and complete, I want you to move them to the EMS waiting room, because remember, we right-clicked on that patient and there's a waiting room button. You're going to put them in the EMS waiting room. Then you're going to right-click on them again and go to patient status. And you're going to go up here and click waiting for MRHP. This is going to allocate them to the MRHP screen, and this is going to close. You're going to right-click on them again, and you're going to put them back and put their status back to EMS Park. The reason we need you to put them to EMS Park is because when they show up on the MRHP screen, they will not have a treatment location, but it will be flagged as EMS Park, and the physicians will know they're out in the hallway. It seems like a really cumbersome workaround, and we had to kind of figure this out just like last week. So this is our quick workaround until we can actually look at maybe getting treatment allocation spaces or holding spaces in the hallway. We do not have H beds. So the H1 to H8 are not part of Connect Care. So the other challenges, what we're talking about is number one, we want to make sure these patients are at least allocate or visible to the physicians to be able to go and see and sign up for. But the other challenge we're going to have is that there's no locations. So you're going to have patients randomly down the hallway and not know where they are. So it's really important to put the armband on. And I think we need to live this. So once we go live, people that are in EMS triage area, I think we need to live this and to see how is the best way to manage so we know what patients. So if we're sending lab, let's say, to go draw blood, it'd be kind of nice to know what area, which hallway space they're in. So we're going to have to figure this out on the go because it's something hard to do in the play environment. So intake patients, nothing has changed. Criteria is still the same. The intake coordinator is going to be watching that intake main waiting room on the screen, calling triage lead or secure messaging them, anything, paging them to send X number of patients back. So you're going to move number of patients back to the main waiting room, and then they're going to drag and drop those patients. So getting those patients back from the main waiting room to intake, again, there's no paperwork, right? So you can't hand 3 charts to the volunteer and say, could you take these people back? So one of my suggestions that we're thinking, we'll see how it works, is just print a label. So the triage lead will print a label for those next 5 patients to go back to intake, put them on a piece of paper and hand that paper to whoever is going to walk those patients back for you. They're going to call them from the waiting room, take them back to the intake desk, and then at least the intake coordinator now has that paper with all their stickers on it, and then can quickly drag and drop those patients into their internal waiting room. So again, then the intake coordinator is going to add priority flags. My apologies, this should be intake area 2. So again, moving that patient, they're going to go from intake from the waiting room and go to intake main waiting room. That's how you're going to do it while they're waiting to go to intake, or from ED manager, you're just going to drag and drop them. Fast track patients, the criteria for fast track patients, they're called fast track in Connect Care. We call them minor patients, whatever you like to do, but they do not have a treatment location in the main waiting room. So we really need to make sure we put that triage destination of fast track. So post triage destination will say fast track. That will just make it easier for the lead when you're allocating bed spaces and putting in your sequencing, your priority flags. Okay, same process. DPOD staff is either going to call triage, walk up to triage, say, hey, I see that there's 6 patients waiting to come back, patient labels and wander them back, and just make sure that whoever's taken them back now move them from the main waiting room and drag them into DPOD. Okay. Now, the other thing, not only do we have triage destinations, post-destination criteria. So we want to know where that you want the patient to go from a triage nurse perspective. The triage lead is going to be putting on a priority flags to help decide who gets in. But it's also super important that we have consistent CTAS scoring. So if all of us as triage nurses are triaging the same, then if you think about it, the MRHP screen is order of CTAS. So we really want to make sure that those CTASs are accurate. We don't want a whole bunch of 5s that actually should be 3s, because that's going to keep pushing them to the bottom. We want to know that they're safe to wait. So we don't want 4s and 5s unless they legitimately should be, right? Because they are going to kind of get to the bottom. The other thing is we don't want a whole bunch of CTAS 1s. Every time we make a CTAS 1, it's just going to keep popping them into above all of those 2s that are sick. So who should be CTAS 1s? Who should be 2s? And again, if we're following CTAS, it should be properly putting off what the acuity should be. Now, the beauty of Connect Care is that with modifiers, when we think about all of our modifiers, we used to kind of we could easily skip over some of our modifiers, especially with the mental health patients. We would click, depression, suicidal, and if you didn't want to do all those other drop-down boxes, you could kind of quickly get down and make them a 3. In Connect Care, I really like the way the CTAS scoring comes up, because you put the chief complaint in, and when you open up the CTAS component of it, they only put relevant information to the chief complaint. So you're not going to see all of this stuff about, mental health and all that. It'll be very much in your face. You can't really override it because it's super easy clicking as you go down. There's no scrolling. So I just think we'll do a much better job using these modifiers because it's a little bit slicker in Connect Care. So I just wanted to cover a couple things where I think where often see CTAS discrepancies that I think we could probably improve on. Number one is our mental health patients. This is actually right from CTAS about what the different priorities are. At a base score for depression, suicidal, their base CTAS score is a 4. However, if they have an uncertain flight risk, active suicide intent, or they have a clear plan, that makes them a 2. If they have no plan, have an ideation or no suicidal ideation, or that is moderately anxious, that can make them a 3. So just depression, suicidal, occasionally we still get them up seeing as a CTAS 4 that end up maybe escalating. Hallucinations, delusions, a base is 5, which is insane, but they really quickly jump up to be a CTAS 2. So are they uncertain flight risk? So these might be your CPS patients sitting in that back hallway that came in with hallucinations. And maybe even if it's drug or alcohol induced, they still end up being a CTAS 2. Acute psychoses, we're usually pretty good about getting those in, and there's a really good opportunity to get these up to a CTAS 1 if they're imminent harm to threat or self to others would automatically make people 1s, right? Same thing with your homicidal and your violent behaviors, minimum 3, but flight risk makes them a 2, imminent harm to self or others makes you a 1. The other thing, the question that keeps coming up is about EMS vital signs and that pre-hospital assessment. So if we think about what our rule of thumb is with triage, is you need to triage what you have before you. Triaging over the phone is actually a completely separate entity, and there's different protocols for triaging patients over the phone, and it's not CTAS. CTAS expects that you have the patient in front of you. You look at your objective, subjective assessment, and you obviously do that critical look and gut findings. Triage is more than clicking buttons. You can go ahead and click buttons. At the end of the day, it's you as an experienced emerge nurse to use your gut and evaluation to look at that patient going, yeah, I'm really worried about them. Or no, I think actually I'm feeling okay with this triage assessment score. So you're looking for that gut instinct, your objective assessment, which is your vital signs, and a subjective assessment. We do ask that you do a set of vital signs in front of you. We want vital signs within the last 10 minutes of arrival to the emergency department. I don't want vitals that were taken 2 hours ago. One, that's a risk if they've deteriorated. And number two, what's going on with the patient now, not what was going on scene. So where this comes up is often the discussion is that patient who EMS patches in, their SATs were 88 or 80 something on scene. They put them on a couple liters of oxygen, or they gave them a Ventolin treatment or whatever it was, and the patient arrives and we do an assessment. You do an assessment. Their SATs are now 90 something on a couple liters of oxygen. They appear in no distress. They look like they might be a little CHF-er, might be a little pneumonia. But they appear otherwise well. And what we were doing is there was, I think, some misinformation going out about basing your CTAS on the fact that they had that original SAT of 88. My concern with that is two. Number one, you didn't see the patient. So that SAT of 88, was it a good reading? Was the patient cold? Was the patient super agitated and walking around and active, and that SAT wasn't actually taken at rest? So you didn't actually have any of that information. So you just based it on a finding from somebody else. And also, what did that patient look like? So was their SATs 88, but they actually were just a little short of breath on exertion, no obvious increased work of breathing, which actually comes up as their respiratory level of distress is actually mild, with a finding of a SAT less than 98. This does not override everything else. Now, if medics say they were tripoding, they couldn't speak a word, I gave them one, puff of Ventolin or one treatment, and it opened them right up, or I gave them a dose of epi, an IM epi, because we thought they were anaphylaxis, then absolutely that patient was in severe shock, then makes it different. But that one finding should not be everything. It should be taken into consideration. So I'm going to triage that patient with my SAT of 90 on 2 liters. When you go into the triage vital signs in Connect Care, it's going to ask for vital signs. You're putting in a SAT of 92%. It's going to give you at minimum a CTAS a CTAS 3, right? Because you're 92 to 94. So your oxygen level itself is not going to bump you up. You are then going to look at your patient and say, what do they look like? Are they mild, moderately, severely distressed? If they are severely distressed and you're like, oh my God, this patient needs to go to be tubed, then go ahead and make them a CTAS 1. And I'm assuming that work of breathing is also on that patch pre-hospital information is going to give you the indication that patient is coming in extremis, and we're going to send them right back to A18 to get them intubated because there's some crazy COVID or something, right? So those ones are obvious, but the ones that are coming in and you're like, yeah, they can go down the EMS hallway, those should not be a CTAS 1. So now let's say I make that patient a CTAS 3. That's their start off. I feel that they're actually, a little bit short of breath on exertion. Otherwise, they're quite comfortable when they're sitting there. I'm going to do the rest of my investigations. Do they have decreased air entry one side? Was there any trauma related? Did they have a fever? And this is a pneumonia. You are taking the entire story and making a really conscious decision about what their triage score is going to be. Now, if you all out that after all of the vital signs and your base that you still come up with a CTAS of 3, what I would do now is take into consideration that pre-hospital information. Does that concern you enough that you want to actually bump them up to a 2? So right now with our acute COVID patients, these patients deteriorate quickly. This is where I think a lot of this came from at the beginning of COVID. Those patients maybe had a low SAT to begin with and quickly deteriorated. If you have those spidey senses, then they should be a 2 and we should be getting them in sooner. But realistically, if it's kind of that patient that looks like they can be managing fine, then you might be able to leave them a 3, or you can go ahead and bump them a 2 and they can safely wait with medics in the hallway with oxygen. The other argument I have for this is if we think about these pre-hospital assessments, we do it for level 1 traumas and we do it for strokes. I totally get that. However, stroke criteria and level 1 trauma activation criteria, actually both research-based criteria that have been proven to demonstrate outcomes of increased morbidity and mortality. So we don't randomly make every trauma a CTAS 1. We make level 1 traumas that meet criteria CTAS 1. Same thing with our strokes, because there is very specific criteria that states that these patients meet a research-based guidelines. So that's why we take pre-hospital vital signs, because it has been shown to impact morbidity mortality. So that's one thing I want to say. So the other thing is about our seizure patients. So if you have a patient that is seizing on scene, then that patient is going to be seizing in front of you, that's going to be a CTAS 1. If the patient seizes at home and arrives to you post-ictal, they are not a CTAS 1 just because they had a seizure at home, they are going to be a CTAS 2. If the patient seizes at home and they arrive and they're awake and talking to you, that technically is a CTAS 3. However, you're always taking things into consideration. If that post-ictal patient maybe fell and hit their head and they're completely unresponsive and they require intubation, they're a CTAS 1. If that post-seizure patient who's awake and talking to you is a CTAS 3 when they arrive, however, this is their 3rd seizure today, I would promptly bump them up to a CTAS 2. That's where you, as that experienced triage nurse, need to use your thought processes rather than just relying on an arbitrary, this I think, particular picture, which I think confuses things. Communication is essential. Private messaging and portable phones, pages, all that kind of stuff are essential to get out there. So what I'm going to do now is actually go into the play environment for a quick little minute here to show you a couple of these things in real life. Okay, so I'm going to just move out of here for a sec. Apologies. Okay, hopefully you guys can still see that. And sign in under train. Oops, if I can. Sorry, I'm just having troubles sharing this. Just give me a second. There we go. All right. Going to continue. I'm going to FNC emerge, and I'm going to continue. And okay, my apologies for that. So what we're going to go now is quickly just go through kind of arriving a patient and showing your screen. There's no patients in my waiting room. Somebody must have moved him for me. I made you one earlier. But this is a screen. So you're going to notice when you sign in on your first day that there's going to be a lot more tabs. There is a whole bunch of workflows we want you guys to do, or a whole bunch of tasks you guys have to do on your first day. We need you to move a whole bunch of these buttons in down just to make things seem less cumbersome. So what we're going to do is going to go and arrive a patient. So there's your arrival button up there. And actually, I'm going to do one more thing. In here, this is your track board. So normally you would be seeing your waiting room. This is your area 3 MRHRP next to C. And this is your overview. And sorry, somebody took my patients out for me, but that's okay. Under here also you have your ED manager. So this is currently what our department looks like. And I think because we're getting ready to go live, my department is completely empty, which is fabulous. However, in here, what we have also is your waiting rooms are down here and your ED manager up top. This is your ED map. Again, looks really super busy. As you can tell, it's kind of cumbersome, and we'll talk more about that in the live environment when we actually get you on scene. We're going to arrive a patient here really quickly. Normally, I would ask you guys to be doing the 5 identifiers, but I can't do that in the train environment. So I'm just going to go ahead and make a patient as female, and we're going to put her birthday as Y minus 30 and accept a new patient there. Okay, so you're going to get this chart that opens up. And in here, what we're going to do is arrive. So you're going to see right now they're expected. I'm going to go and arrive this patient because they're physically in front of me. And I'm going to go ahead and click arrived. When you do that, it's already time-stamped at the time of arrival for this person. So you want to make sure that you don't click any other buttons. Your room date doesn't need to be done. Mode of arrival is just walking in, so no ambulance. And again, this patient is standing in front of me at triage, and that's all I need to do for arrival. They've gone from arrived to waiting room. Your armband is going to print off. The next thing you're going to do is travel exposure screening. So you're going to go ahead and open that up. There is the typical unable to assess, just like we currently have always done. And there's no difference to that as there has been before. We ask you to make sure you mark that they've done some respiratory hygiene and are in a mask. And then there's the stuff about COVID immunizations. I'm going to say she's fully immunized. She does not have a fever, a cough, or a rash. And then our COVID-19 symptoms. I'm going to give her a vomiting, abdominal pain kind of scenario, but she's got no other COVID risk factors. There is an option to put no COVID symptom risk factors here. And then there's recent travel. Has she traveled outside Canada? And you're going to go ahead and put yes. And if I've traveled to communicable disease and you don't know what those are, there is an emerging pathogens button. This is my little plug-in reminder about Ebola. So it is currently broken. So Ebola should be popping up in here. It'll talk about where the current emerging pathogens. So if you need anything, Ebola information for healthcare providers, will have all of the information in here as well. Okay. And so I'm going to say that it was not to an active region. So I'm going to put no and close that. You can either close or hit F8, but make sure you do one or the other. Because I put the patient in as vomiting, it's going to get a flag for isolation. There is no isolation, well, there is isolation orders, I shouldn't say, but emerge, we are only going to change isolation status. Isolation orders only need to go in when after the patient is going to get admitted. So we're going to go ahead and initiate isolation. You're going to change the status. So do not go ahead and put an order in unless the patient is going to an inpatient unit. Isolation status, we're going to change to contact droplet. You can write something in there if you want, but just for time, I'm going to skip that and add new. You'll see over here now that her isolation status has changed to contact droplet. Okay, I'm going to F8 to go to the next arrival and the pre-arrival information. Because she's here, I'm not doing any pre-arrival, so I'm going to go to the next one down, which is ED notes. This opens up on the side over here, and the cool thing about this one is I'm going to write triage because that's my first triage note. This is like that little narrative part we have in SEC triage right now, but you have unlimited characters. I recommend you do not use the unlimited characters and chart a story, but this is where you're going to be able to kind of chart away. Now, the nice thing is you can go to ED notes and start typing other things and leave this open to the side. So depending on how you like to communicate, how you like to chart, you can go ahead and I'm going to do some abdominal pain. I'm going to say, yeah, she had some vomiting. So I'm going to find nausea and vomitings right there. I'm going to put nausea, vomiting, and you're going to say ABD pain times 2 and 7 with vomiting. And you're like, you know what? I'm actually more worried about her belly pain because I think she might actually be an appy. So I'm going to switch that to abdominal pain. What you're going to notice, one thing that I'm not sure why it's available in Connect Care, but you actually can pick more than one chief complaint. So you'll see nausea and vomiting and abdominal pain there. The other thing you'll see is that underneath abdominal pain, whenever you pick a chief complaint, there's a comment section. We don't want you guys, I think some urgent care centers might be having you guys doing your documentation here. We really want it under ED notes. The reason is these pull up under your narrator when you actually look at the patient chart in a much easier fashion so you can actually see the story better. So I want you guys really to get in the habit of doing ED notes and to skip over this comments. The other thing, though, is that just because you can pick two chief complaints, I don't want you to. So you are going to go over there and I'm actually going to delete that nausea, vomiting, and leave abdominal pain as my chief complaint. I can close that, continue with my ED note over here as I go along. I'm going to put some vitals in as, oops, I don't want to give her febrile 37. She's tympanic. Again, one challenge with Connect Care is there's so many buttons, you feel obligated to click things. You are still only going to fill in what is relevant and valid to the patient's presentation, okay? So oxygen therapy, walking, all that stuff. There's a great place to put this. She's a GCS of 15. It's going to show up as a modifier anyway. There's a weight in here that you have to actually manage, not obviously at triage, but that's where you're going to find your weights. I'm going to close my vitals. The next thing, they all show up here right now. You'll notice my heart rate has actually been flagged as outside normal limits. That's awesome. There's a pain option here. I'm going to say that she is a 7 out of 10 pain, acute, and central. Okay, close that. The next thing open is going to be my CTAS. So the CTAS is going to open up. I just have to move that over for you. You'll see that what it does is number one, it's got chief complaints up here. It's got your abdominal pain. If you choose to change your chief complaint in here, it will change it to be one single one. So you can actually change it once in here if you feel there's something more appropriate. But in the first one, please only put one. I've got my chief complaint. It's got the respiratory distress. It's already marked off her vital signs outside normal limits because of that heart rate. Her level of consciousness. It asks you about any SIRS and temperature concerns. It pre-filled your pain score based on what you mentioned, and it's got your frailty tag there if the patient's frail. One thing I had to get used to as well, if something is highlighted, I really feel the need to click it. However, if you click it, you're actually turning it off. It has been pre-selected for you, so just leave it. And if you're happy with that CTAS of a 3, you can close. You can also go in and actually click emergent and actually put the override reason, but I think this is disappearing. So you can go ahead and click emergent and actually close and make sure a CTAS 2. Before you leave CTAS, I want you to put a triage destination. So this is where you get your intake, acute, fast track. So the difference that our terminology is set within Connect Care. So intake is intake. Acute is actually BPOD monitored beds because monitored beds are our APOD beds. So that's just some terminology we need to get used to. So acute is BPOD, monitored is APOD and trauma. Fast track is DPOD. And then you have something called addictions and mental health. You can go ahead and click this one that they want, what it does is it flags that they can go to addictions and mental health. But it also can flag that maybe I want an EPOD bed. The other difference is as soon as you flag them as addictions and mental health, it will show up on our colleague screen in PES. So the PES nurses will actually see every patient that we've flagged as addictions and mental health, which will actually help identify them as well. So you can go ahead and put them addictions to mental health. And then you obviously as a triage lead would figure out if they can go to APOD or APOD, EPOD, or BPOD based on your assessment. We don't tend to allocate patients to the recess room. They get as to sit in the waiting room, they go right back. And we do not allocate pediatric patients. We have no pediatric specific area. So I'm going to say this patient could go to intake and I'm going to close that off. The other stuff in here, we are now actually in the waiting room. This patient has been completely triaged. Some of the other stuff over here that I want you to kind of look at because it feels like we have like an obligation to fill out. There's a team activation, which we wouldn't do for this particular patient, but you could go ahead and document that you page somebody out. Triage disposition, if we decide this patient, this is where I'm going to send them to L&D, if my L&D referral. The RN referral would be my PCN referral, or if this patient left without getting registered and left after triaging. There's also a drop-down box in here as well, where you have the sent to labor and delivery. There's a send to cath lab. So you can have all sorts of things in here as well. Okay. EMS consolidation is on here. We are not using this. I don't want you documenting whether or not we have consolidated EMS patients. It's not our job to do that. EMS handoff is also in here. This tells me that you've actually taken a report from the physician or from the medical crew and that you've downloaded this patient to the waiting room. Do not do this if they're staying in the EMS hallway. There is an electronic version of the PCN referral form. Also, we are not using this. It is here, but we have no way of sending this electronic form to our PCN colleagues. So we are staying with the paper form. There is allergies in here that if you give medications to patients, we are not asking that you do allergies on all of your triage patients. We are, however, asking if the patient is female and happens to be pregnant. If you go under OBGYN status, I'm going to click that she's pregnant. So she's had belly pain for 2 days with nausea and vomiting. It's right lower quadrant. You're thinking she's much more of an appy, no spotting, but we'll say that she's 6 weeks. Gestation. So I just want to mark off that she's pregnant. The reason is, and I'll show you that, once I mark off she's pregnant and sign it, if you look over here, it actually now identifies she's pregnant. This is super important for you as a bedside nurse. You can now look at that patient and sign up and you'll immediately know that there's a pregnancy status on there. The other thing is this patient will also be flagged up in our labor and delivery colleagues. They have a system in Connect Care called Stork, and it will tell them we have a pregnant patient in our department. Whether they need to see them or not may come up later. Medications, Medirect status, history. If you go into history, there is such things as, marking off hypertension. You can go ahead and do this if you want, but then you have to scroll all the way down to the bottom, which is really long, to accept it. It's also perfectly acceptable to write that into your ED note. Fall risk domestic violence, we are not doing at Triage. A violence assessment screening tool we are not currently doing, but likely in the new year. And all the other stuff is bedside. Once you are completed that, you need to remember to sign your triage note, and then that will end up populating into your ED narrator as part of your chart. Okay, I'm going to dismiss that for now. So if you decide that you think, oh, I really wanted to give this patient some Tylenol while they're waiting in the waiting room, there is no quick little, triage protocol button. You are going to go to orders. You're going to go to quick lists. Oops, I have to do an allergy activity. I'm going to say no more allergies really quickly there. I'm going to go to quick lists, and you will notice that not only does it create order sets, which we are not going to use, there's verbal orders in here, but there's also nurse implemented orders. Under here, you're going to find your Tylenol, and you're going to say, I'm going to give 1,000 milligrams and accept. And now I've got my new order. I'm going to review my order and sign it. And I need to say that it is per protocol. No cosign. My ordering provider, just like now, is Emerge Protocol. And if it's not on your screen, you can type up Emerge and Emerge Protocol and click them and accept. That order is now here. If I go into my orders, it'll be under MAR. You can go ahead and click it here, or if you guys remember your little scanners, you can click the patient. A screen will open up to say that you're giving Tylenol. You're going to scan your patient. You're going to scan your med, and you give it. In here, when I click my med, I'm going to scan the patient barcode. If my barcode, I'm just going to say that my barcode's not working, just to show you what happens. I'm going to scan the medication. And again, I'm going to just say that scan got broken. And you're going to go into administration details. It's got the oral, 1,000 milligrams. It's set a time. It tells you what the pain score is. If the pain score is changed, you can change that. And I'm going to sign off my med. Easy peasy. Okay. I'm going to do one more patient. We're going to pre-arrive a patient. I'm going to arrive a patient, but instead of, I'm going to put another anonymous. I'm going to make a male. It's going to be a cardiac arrest coming in, and he is a Y minus 88-year-old man. Poor little guy. Now going in, the patient is already expected. So instead of clicking arrived or roomed, I'm going to put expect. So expect is T for today. Expected time is for now plus 20 minutes. Okay, and that's telling my arrival time. I'm going to put a hold on bed trauma bay 1. And they're coming in, let's say, by ground ambulance. There we go. And I'm going to say cardiac arrest from LTC. Goals of care was an R1 because you got that in your patch. So super important information for everybody to know. So now I can't triage them. I'm still expected. If I start my triage note, it's boots on the ground. It says the patient has arrived. So the next thing you can do though is go to pre-arrival information. So my pre-arrival is that he's actually a cardiac arrest. If there's other things you want to say, there's that little drop down button. I've activated, you can say I've activated my team. I've called the cath lab or cardiology if there's anybody else. This is where you could document what was on the patch form, but there's a lot of stuff in here. If this was a trauma patient, you could go ahead and document vital signs in there. Any medications like the fact that they received 2 units of pack cells would be lovely. And the additional information would be whatever else in here. I'm just going to googly gook in there just for now. And you can go ahead and close. Okay, so that information is in your pre-arrival information. If I go back to my ED manager, this is where my ED manager is, and I'm just going to try and squeeze some of this up. Sometimes it works to make it smaller and bigger in the share screen. Oh, there we are. There we go. Baltimore Bank. So if I hover over him, I have 3 patients similar to that name. So I'm going to scroll through because I've got so many unknown patients. So I need to find my expected patient. Here's my cardiac arrest that I was expecting. So I'm going to go double click on that patient when he arrives. And I'm going to go click my arrival information. And he's now arrived. I'm going to go ahead and click roomed. I'm going to go to Trauma Bay 1. I can change it if it didn't work. I'm going to close that out and I'm going to send the medics down the hallway with their armband and the patch form and their labels. I'm now going to go in and quickly do my travel exposure screening. He's unable to assess. And I'm going to say close. I'm going to just defer that because I just showed you guys how to do that. I wouldn't normally recommend that. I'm going to open up my ED notes and put triage, CPR in progress. Now this seems like it's gonna be cumbersome, but the medics are already on the way back. The patient is, excuse me, already back in Trauma Bay 1. And the cool thing is your colleagues in the back can already open up the ED narrator and start the code narrator while you're finishing your triage note. So CPR in progress, sent to Trauma Bay 1, whatever you want to put in there. And I'm gonna sign that off. I have to put in a chief complaint and I'm going to put arrest. So you have a way to type things in there and do a search. Okay, non-traumatic cardiac arrest. And these tabs, you can wrench in a whole bunch of tabs if you want. Vitals and pain, I'm going to skip over because I'm expediting triage. My CTAS is a 1, which is already selected, and I'm going to close that. And my team activation is already done, and I did my arrest. So I'm going to just go ahead and close that. The patient is now in Trauma Bay 1, and if they go under the ED narrator, they can go straight to, we're going to dismiss those. They're just going to go straight to the code narrator, and they can start documenting on that patient without us even having to finish our triage score. Okay. Just to get out of there for a second, I want to go back to the ED trackboard. Here you now have that patient in our initial one that was going to intake. There we go, priority placement. It's going to make these columns bigger so you can actually see what they are. I would love it if we had more patients there for you to see, but however, there's your acuity for that patient, my post-triage destination. Again, these columns do not show up in this order when you guys go live for the first time, so we'll have to show you how to do that. If I want to give a priority placement to that patient, I just double click and I'm going to say next in CTAS and accept. And then my little dot's going to come up. And so that would be next in CTAS for the intake to go to the intake area. So that would be the one I would send in. If I go to my MRHP, what I'm going to do is actually going to right click on this patient and I am going to room them into intake. Fine. So I'm going to put them into B9 just for fun, just to get them out of my way. So I'm going to room that patient into B9. I'm going to go into my MRHP next to C screen. Got 2 patients in there, and now here's my sequencing flag. So according to the physicians, they're going to see this patient and then that patient, which makes reasonable sense. If for some reason I would never do this, but I'm going to make a next on this one because there's something wrong with them. And that would now bump that patient for the physician to see. Not realistic, this is my code, I get that, but this would be how that would work. Okay. All right. So that is the end of the presentation that I have for you guys. And I really recommend you guys get up to Triage as much as you possibly can before the end of the month, because we are going to have lots of help up there and we'll have lots of resources for you. So I thank you so much for taking the time to listen to this. And I hope it was super helpful. And I'm sure we'll be all learning about all these idiosyncrasies and nuances with Connect Care along the way together. So thank you and have a super day.